morning. Thanks, Kshitij. And I'm quite happy to see we also have combination of orthopedic surgeons and also radiologists. So it's kind of a tricky topic for me. How we combine two things, how we get the radiology and the orthopedic surgeons on one platform. So as we know, we are an arthroscopic surgeons. So when we talk about rotator cuff tears, we as a clinician, we face wide variety of conditions, having cuff tears from kind of a small partial tears, which may be 3 to 4 millimeters, to massive tears. Patients coming up with different reasons can be a traumatic or a degenerative cuff tear with various age category, chronicity, and associated pathologies. So to get all these factors into one kind of a platform, we require a good understanding between the clinician and the radiologist. So when we diagnose rotator cuff tears, we know the clinical examination is important. X-rays and sonography still has limited values. We still prefer MRI as an investigation of choice for multiple reasons, but as an arthroscopic surgeon, we believe that what we see is what we believe. So the purpose of this talk is that how do we diagnose rotator cuff tears at clinic? So that's examination and MRI. How do we predict the extent and the severity of the cuff tear? How do we assess the repairability? Is this tear going to be repairable or non-repairable? Are we going to conserve or operate? And if we're going to operate, we are going to scope this joint or we're going to do an open kind of a procedure. So let's consider this first case. As seen classical, this patient is something like a drop arm test, not able to raise his hand. So this is a clear-cut case and has got a cuff tear. So this is a very straightforward case on clinical examination. And once we know this, it's a cuff tear, then we do various kind of tests to assess the further issues with the same problem. And then we have this next patient walking, and the same case where the patient is not able to raise his hand, and it looks a similar clinical condition, and then we do his MRI, and the MRI turns out to be normal. And then we are confused. The same clinical presentation, and it's the same thing with the MRI looks quite normal. And then we are in a problem. What is this case? And then we start investigating him, and there is a large acute disc prolapse. So this is where your MRI comes very handy, and MRI definitely outweighs your clinical findings. Let's understand how MRI and clinical examination has been correlated with arthroscopy. I did not find any kind of studies where they compared the clinical findings and the MRI findings for the correlation of rotator cuff tears. But definitely there is a lot of literature available for the correlation of clinical test and arthroscopy and MRI and arthroscopy. And we found that in cases of infraspinatus, the parameters are equivocal, but for supra and more likely for subscapularis, your MRI is more specific. There's another study where they again compared the clinical findings with arthroscopy and an MRI and arthroscopy and found more sensitivity and accuracy on the MRI findings. So when we do an MRI, we do kind of battery of further investigations where we look for anatomical and functional factors. Anatomy, we look for the number of tendons involved, the size, and for the function, we look for the atrophy, the fatty infiltration, and the presence of posterior inferior cuff. So that's the site of the tear. We grade the tear according to the size of the lesion, and we look for the fatty infiltration depending upon from grade 0 to grade 4. And we also look for the muscle atrophy called as the tangent sign or the scapular ratio. So once we have done with this clinical test, we decide whether the cuff is repairable depending on the age, is evidence of trauma, the size of tears, the number of tendons involved, the chronicity, any kind of arthritic changes on the X-rays, arthropathies, and if patient has got a good muscle bulk and a lesser amount of fatty infiltration, we more or less can label this patient as a repairable cuff tears. But what happens to the other side of the tears? Well, the age is more. They have a degenerative tears, a larger size, presence of a posterior inferior cuff tear, larger patients with long chronic Hamadas type 3, arthropathies, and evidence of muscle atrophy and fatty infiltration tells us that these tears are more or less irreparable. So that's something for the audience. This is a Hornblower's sign with a teres minor tear. So this tells us that this patient probably has got an irreparable cuff tear. So that was the first part where MRI is very important and it will definitely outweigh the clinics. But we also have a scenario where MRI is as important as clinics. So you cannot escape your clinical examination. Let's consider this case. This patient, a middle-aged female, walked in with acute traumatic shoulder dislocation, and then we reduced the shoulder. The standard format by any orthopedic surgeon, will brace this patient and send home, and probably call them after about 3 to 4 weeks. But we understand these patients, if you don't know what, as I rightly mentioned to Aditya, your eyes don't see what your mind doesn't know. This patient came to back with a reduced shoulder, but then had a large cuff tear, which we missed on the initial examination. So we missed this patient at an acute setting where she had a traumatic cuff tear, and we lost a golden opportunity to repair this tear. So here, your clinics is also as equally important as your MRI findings. But there are certain cases where your clinics are more important than MRI. Let's discuss few cases. So let's look at this partial cuff test, which has been widely studied but has got less clinical significance in our practice. So they have labeled them as bursal site tear, articular site tear, interstitial tear, and to add more confusion, we have this pasta and paint lesions. But frankly, we don't take it much seriously, and it has got less clinical importance when you're talking about these kind of tears. There is also important that there is also doubt that if we are going to repair these tears or you're going to treat this, are they actually going to benefit these patients? So definitely they have got limited accuracy. There is also a paper which says that a lot of these focal tendinitis patients are overdiagnosed as partial cuff tears. And this is something which is scary and worrisome. These kind of partial tears has led to unnecessary increase in the diagnosis and surgery. So a lot of times they've observed as increase in arthroscopic surgeries for this partial cuff tears. So partial cuff tears are definitely, sensitivity is about 100 and about specificity 86%. So this 14% of patients are undergoing unnecessary arthroscopic procedures. What about glomeruloarthritis? It has been shown in the glomeruloarthritis, the cuff tears are overreported and they have got low predictive value and quite low sensitivity. So in cases of glomeruloarthritis, the interpretation of cuff tear is very doubtful. Muscle atrophy is widely debated. We have discussed that muscle atrophy is one of the important factors for an irreparable cuff tear, but there are certain pitfalls in that. We know that we have a certain bony landmark to identify the supraspinatus tear, but similar thing is not available for the subscap. And it has also been now known that even if we have got a muscle atrophy of subscapularis tendon, we can still go and repair the subscap with fairly good results. There has also been a lot of discussion where they have said that even if you have got a preoperative muscle atrophy or a fatty infiltration, even if you go and repair these tendons, they will still give a fairly good results. As against the muscle atrophy, I did not find any kind of literature or information on the tendon atrophy, and we need the more study on tendon atrophy because the size of the residual tendon and the dimension is very, very critical for a successful cuff repair. So that's our algorithm for a cuff repair depending on our MRI and clinical findings. So at the conclusion, we don't have a standard test, standard clinics, X-ray or an MRI to diagnose what is true for this patient and what is right for that particular patient. But I think so we all require cooperation between various clinical and investigating parameters for a successful surgery. Thank you.